All right. So, so quick recap. So again, please do exam 2 before the end of this evening, because 9 o'clock it's going to close down. The quiz is going to go from 7/17 to July 24th. And I'll be sending off, I'll do it probably Monday with some directions how to do a super build, one you'll do by hand. You've been doing them on SimChart electronically, but I need you to do one actually by hand. And, you know, again, everybody seems to be keeping up now on the SimChart exercises, and I've gone in and graded anything that is there today. So just recheck it and recheck them and see if you have one that I'm asking you to redo. All right, so let me see if I can screen share. Do you see the slideshow?
Yes.
No, I'm getting better. Okay, so we're going to cover tonight Chapter 17. It's on insurance and billing. So billing is obviously it's an integral part of what we do, and it's very important that we, for better or for worse, capture what is rightfully ours. So you want to be sure that you're getting, and that's really for the coders. So if it's really crucial for coders to make sure that we are actually billing what we're entitled to and not billing over what we shouldn't be getting. So they review our documentation, they review what's been submitted, and try and make sure again that we get what's rightfully ours. Because remember, billing, getting our money back is what's going to pay our salaries. It's going to pay the electric bill, the heating bill, the rent, everything for the facility that we're working in. So it's really important that we do this and we do it right. Because again, you don't want to leave money on the table. It's important that we get what is rightfully ours. So here's some of the basic insurance terminology. So the premiums. So the premium is actually what we pay to have our insurance. So every one of us has some form of insurance. With Obamacare, there was a requirement that all of us had to be insured. So we could do it through a private agency, or we could do it through a government agency, or you risk penalty. So that's what the premium is. That's what we pay to actually have the insurance. So it's either taken out of your paycheck, or you pay it on your own. Kind of like some people pay for their own insurance on their own. Many times you see patients such that might have Medicare carry a supplemental insurance to help pay for the additional 20% that might be remaining, because Medicare is an 80-20 plan. So Medicare only covers 80% of what they believe is the expected part of the bill that they will pay. The remaining 20% is owed by the hang on, I'm going to lose power here. I'm going to plug this in. Remaining 20% is what is owed by the actual policyholder. The benefits are what are the payments for the medical services provided. So this is typically where patients get confused, and they or not just patients, the policyholder gets confused because they don't understand what their plan has as far as the benefits. You typically see at the beginning of the year, suddenly when everybody's insurance resets, and they might be responsible for a large balance because they've got to cover it. It's part of their insurance. So it's important that each of us understand what is our benefit package, what can we get, what do we get for the insurance we pay for, what's essentially covered. Dependents are your spouse, your wife, your wife, husband, children. Of the insured person, okay? Third-party payer, what third-party payer means is just the actual insurance or the health plan that you have. Blue Cross Blue Shield is a third-party payer, Aetna, Health New England, you know, Medicare. Those are were considered a third-party payer. Okay, so so the deductible, and that's that's along with your copay. So those are typically the things that people kind of forget. All of a sudden, resets come January 1st, that their deductible it comes back in full. So you have to, many times with your insurance, meet your deductible before your plan will actually even touch the bill. And that again means, you know, the individuals need to really clearly understand what is my benefit package, in what does it encompass. And then a co-insurances might be something that's owed after the deductible is met, a percent owed. Co-payment, no, co-payments are typically due at the time of the visit. My recommendation with co-payments is that they happen when the patient arrives. The textbook talks about capturing the co-payment on when the patient's exiting. I've not seen that as a real workflow process, but my recommendation is, you know, I'm not going to test you on it, but most places you capture co-payment on arrival. You're at risk not to get it. It is really important to get that co-payment because it's a piece of the bill. It's a part of the bill. So if the office visit is $150 and you submit it to the insurance, you know, and the patient has a $25 copay, so $150 and then a $25 copay. And then if the insurance company says, oh, we're only going to pay $80 for the bill, so that means, you know, we get $80 from the insurance, but we still got that $25 copay. So that means we got $105, the $80 from the insurance company and the $25 for the copay. So we got $105 for what we wanted to get was originally a $150 bill. You do not always get what you bill for in healthcare. And we'll talk about that later down in the semester. I have a, it's not a video, it's more of an audio lesson around medical jargon. And it explains that, you know, clearly that, you know, there are times, you know, not times, it's reality. We do charge for a higher amount, but we don't get it. So many times healthcare kind of can look like the bad guy because everybody sees these enormous bills that are presented in the news, but the reality of it is we don't get that. We get what we get paid, what the payers pay, and the insurance companies pay, and most of them will follow suit with Medicare. So that's the co-payment. Elective procedure, that's a planned procedure. So it's interesting. You probably heard a lot about. So you probably heard, or maybe you haven't, with COVID. Most states, most governors have held off on elective procedures and have told hospitals, you know, no electives, only urgents. So elective procedure is just that. It's a planned procedure. It's not essential to your care at this moment in time. You know, your life's not dependent on it. But you know, are they necessary? Yeah, sure they are. And if you hold off on elective procedure for a long period of time, they certainly might become urgent. So we've seen that where over the last, you know, 11, 12 weeks with COVID, that a lot of elective procedures have kind of been shelved. Now hospitals are beginning to start back up, and they're trying to get through all these elective procedures at the same time while they're trying to still deal with the sick patients, not COVID, but just patients that are just, you know, naturally sick. You know, emergency cardiac care. It might be, bone fractures or whatever. So on top of all the normal things that we're dealing with, we're now still trying to, you know, dig through the elective procedures that have kind of been, you know, put on the shelf for the last 12 weeks. A pre-certification, a pre-authorization, those are usually what are required from a healthcare agency or a third-party payer, that you get that prior to the individual having the care that's been requested, whether it's a procedural visit or an office visit. If it requires a prior auth from that insurance company and you don't get it, and you do the work, the patient's at risk of full payment. So we have to, as the ordering provider, do our due diligence to make sure that we don't put our patients in harm's way. If we order something on a patient, you have to make sure that you've done the task to get the prior authorization. With Medicare, there's also a process, and it's called an ABN, an Advanced Beneficiary Notice, and that's very much the same thing. You can actually, it's a tool you can actually put on your computers at work to run it for Medicare. Most places have it, but because most of the other payers follow suit, you can run ABNs for other things for other payers, and they're probably going to be very similar if whatever you're requesting for that patient requires a prior authorization. Fee schedules and charges. All right. So those are typically what you see the facility charges for the bill. Later in the semester, when I share the audio video, whatever you want to call it, it'll explain to you. It'll explain the fee schedule. Well, not explain it. It'll show you examples of them. So a fee schedule is essentially what we charge. It is what we've determined and what we feel is the value for what we do. Everybody's fee schedule can be a little bit different depending on depending on the area that you physically live in. So, you know, patients that live in an inner city like Hartford or Boston or anywhere that's within the inner city, your fee schedules are typically going to be higher because the cost of care is going to typically be higher in order to keep physicians, nursing staff, all staff, you know, paid in in inner city. If you go out into the Midwest, Boise, Idaho, or, you know, up to Alaska, you know, your fee schedules be a whole lot different. So if somebody having knee surgery in Hartford versus somebody having knee surgery in Boise, Idaho, is going to be considerably different is what they're charging. But it's not that they're overcharging, it's just that the cost of living is different. Okay. So we're entitled to get what we need to do to maintain the cost of living for the individuals that are working doing the care. So that's your fee schedule. When we do the super bill, you will see on the super bill it shows the charges for the procedures that the doctor is going to be ordering. That's very rare that you actually see it on a super bill or an encounter form. That's going to be called either or. But for the exercise that you'll do next week, it shows it because you need to see it for the exercise. You're going to be ordering some procedures on a woman that had chest pain, journal chest pain, and there's a variety of tests the doctor wants to have done. And I don't know if you've ever, well, you probably have. You've gone to the doctor's office, they've sat there, and they've decided they want to do a variety of tests on you. They start checking off some procedures, whether it's blood tests, chest x-ray, whatever, doesn't matter. And they tell you to go have those procedures done, and they sign it. That's a super bill or an encounter form, whatever you want to call it. It doesn't really show you what the charges are, but on the exercise that you're going to do, it does show you what each individual procedure's charges, because you're going to need to do it to figure out the bill in the end. But that's essentially where you pull the fee schedule from, is from what we do and how we base what we do. And you want to make sure that you're at least getting what it costs you to at the most minimum to do the test. So there's actually, it's pretty trivial, but the way we actually figure out most of our billing procedures are, you factor in the cost of the doctor for the time that you're doing the procedure. You kind of factor in as best you can the cost of the space, the rental space by square foot, the staff that are assisting the physician, what might be the percent of the, you know, the facility charges. And then when you come up with that initial cost, what it costs you to do the test, most of us times it by 3. So if we figure out, oh, it costs us about $100 between the physician, staff, and the rent of the facility for that period of time, and it's $100. The problem is if we get paid less than 100, then we're going to go out of business. So you got to make the money back that you're actually you know, that it's actually costing you. You can't go less than what something costs you, because if you do, you're going to go out of business. So we usually times it by 3. So we would bill the insurance companies $300. It's there. We're hoping that they're going to come back and say, okay, we're not giving you 300. We're going to give you 210. So at least we get what it costs us, but we have an opportunity to make some money too. It is what it is. We're a business. Healthcare is a business. We have to make money in order to buy new equipment, in order to retain our staff, in order to keep our staff competitive with salaries. So, but it is challenging, because again, there are some payers that might not pay you what you want to get. And one of those, well, and they're actually not really an insurance company, but they are a payer, is Medicaid. So Medicaid typically barely comes in at the minimum. So again, so maybe it costs us $100 to do the test. You might get back $95 from Medicaid. It's okay, but if Medicaid is your biggest payer, and if that's your biggest percent of your payers, you're going to go out of business. So you have to look at your payer mix of where you are. You have to have some. Usually people do far better if they have a high payer mix of Medicaid, Medicare, and or Blue Cross Blue Shield or Aetna. So those are usually the 3 you want to hope that those are the ones that you want to hope that the area that you serve is going to come in as at least your highest one. Any questions on that? That makes sense. Capitation. So capitation is typically done with HMOs or PPOs. So what how capitation works, physicians that work for an HMO, they get a certain amount per head that they see. So if their panel is 100 or 400 patients, every month that physician gets paid a certain amount. So they have a capitated fee, whether they see the patient or they don't. Sometimes this can incentivize them not to well, it actually should incentivize them not to jump to the highest level of care, because it's a good way to force them to appropriately medically manage that patient and start slowly. So if the patient is coming in again having maybe chest pain, you're not going to jump to open heart surgery. You're going to start off slow. You're going to have an EKG. Look at the EKG. How does it look? Are they having an arrhythmia? If that looks normal and they're still having chest pain, maybe you have a stress test and see how they're doing. So with HMOs, it kind of slowed the process in how people actually utilized healthcare. It was actually a very good way to begin the process of really appropriately managing it, because in its heyday in healthcare, when Medicare first came out in the 60s, it was abused, and we saw physicians doing things you will never see again in your lifetime. In the 60s or early 70s, women, when they'd have a baby, they'd go into delivery, and then they'd spend a week in the hospital. But that we don't. I mean, if any of you are mothers, I'm sure you know that doesn't exist today. You have your child, and the clock starts ticking, and the quicker they get you out, the better they are off themselves financially. It is what it is, but they're forced to try and shore up the amount of time that individuals are staying within the institution, the brick and mortar. PPOs are actually one of the best ones. So it's a preferred provider, and that's typically where people. It's kind of like an HMO, but it's a little one in overdrive, because you're actually able to go outside of the bricks and mortar. So that means you don't have to stay directly within the HMO. You can be referred out. So here, these are pretty much our biggest ones: Blue Cross Blue Shield, the Blues, Aetna. Those are your biggest commercial payers. You have your private commercial carriers. So we have to carry some insurance for our physicians, not some, a lot of insurance. And depending on the state you're in, it can be quite high. I know Massachusetts, one of the highest ones we have in Massachusetts, I think, is obstetrics. A lot of lawsuits in OB. A lot of that results from, every woman wants to have a normal pregnancy, and it's not always the case. And we see a lot of lawsuits in OB. think Connecticut, I think one of your highest in Connecticut is anesthesia. I'm pretty sure anesthesia is pretty much one of the ones on the top of your list um, for lawsuits. Disability insurance. So most employers have to carry disability insurance as well. So they're just other forms of insurances, the commercial payers that we work with in the healthcare environment. The patient-centered home. So the patient-centered home is how you look at patients over time, how you manage care, or I don't know if you ever heard the word population management. It's taking a look at an individual and in clearly understanding from the very beginning to the not much what I can't really say the end, because it's almost like a continuous circle. So maybe an example might be a patient-centered home might be the patient has a cardiologist. If the patient has cardiac issues, they might have to have cardiac surgery. So they have cardiac surgery. We might own or partner with a gym or have our own cardiac rehab, so that they stay in and within our program, and then maybe even after they get better after being at the gym a while, we redirect them to a YMCA or another facility that we approve and work with to make sure that they maintain a certain criteria. But again, it's all around quality. It's around safety, and it's with some direction from us, the primary. Well, I don't want to say the primary. The patient caregiver. So it typically starts with the primary care doctor, and then it kind of spokes out to all the other areas. But that's the patient-centered home, and it looks at the whole comprehensive care, and most of it is done and based on population health. It might be heart failure, it might be family practice, whatever. So government plans for insurance. So Medicare is our biggest one. So when they talk about Part A and they talk about Part B, they're talking about Part A is on the hospital side, Part B is on the ambulatory or the practice side, the doctor side, and how they bill. So Part A covers inpatient care. Anytime you go in the hospital, and that's just not for Medicare. There's Part A and Part B for all payers, but the book talks about Medicare. So you have your Part A and B. So Part A would be hospital care, nursing homes, hospice care, mental health facilities, psych facilities, rehab facilities. So those would be your Part A, and those are even surgical procedures. All procedures typically fall under Part A, if they are within the bricks and mortar of a health system. Okay, so a doctor's office that's freestanding, sitting out in the middle of Hartford, and they're not attached to a hospital, cannot bill Part A, even if they do procedures. They can do procedures, but they have to bill them out as a Part B coverage. It's at a lot less of a charge. When you are billing Part A, you have to meet a lot of criteria, and a lot of that criteria is around the facilities that you're in. Hospitals have to meet a lot stricter criteria for the facility than an ambulatory setting might need to. There's a certain amount of square footage the hallways have to be. There's a certain amount of restrooms that have to be utilized. You have to meet certain criteria for the size of the nursing stations. Everything is government controlled, and there's a lot more restrictions for Part A coverage. And that's why you can get more money for Part A. There was, during the last probably 5-6 years, a lot of movement to redevelop some physician offices to become Part A, so they could actually bill at that high level. Now the government's pretty much getting tired of it, and they're putting more restrictions now, saying, well, if you're not within a certain amount of yards from a hospital, we're not going to consider that any longer. So that gravy train is kind of coming to an end. Medicare Part B, that's the physician side. That's the physician, the outpatient procedures, voluntary programs. That's all Part B. So when a physician, but it's not just outpatient. So Part B is not always just outpatient. It can also be. So let's take surgery. So if a physician does open heart surgery, the hospital gets to charge for the actual surgery. They charge for the minutes, all the, if any devices were used, if they were replacing a valve, or if they were doing anything, an aortic graft, anything. So the hospital gets to bill for all that. The physician does get to bill for their time, and just their time, and that would be the Part B billing. Okay. So everybody gets a Part A and a Part B when it comes to their insurance companies. Medicare Part C, that's your managed care options. That's your PPO and HMOs. Your Part D is your prescription drug plans. The recovery audit contractual program, I'm not going to expect that you know much about that. But the Part D is just the prescription drug plan. Medicaid, okay, so with Medicaid, and when you accept assignment, you accept the fact that you're going to get paid whatever Medicaid gives you. And that's actually the case, not just for Medicaid, that's for any payer. The minute we say we're going to accept this patient, even if you're Blue Cross Blue Shield, and if we accept assignment, and in Blue Cross Blue Shield says that they're only going to pay us, and we bill them 300 and they're only going to give us back 240, that's what we get back. We can't go after the patient for the remaining balance. Okay, but that's what is determined by accepting balance. Dual coverage, you can have dual coverage for Medicare patients, and most will carry additional coverage. State guidelines, you have to verify eligibility per visit. You have to authorize the needs unless they're an emergency. Time limits, there's time limits. You have to treat with patients with professionalism. Again, it's not really an insurance, and so it's kind of a it's a moment in time when individuals go on Medicaid. It's not meant that you stay on it forever, but there is a level they have to accept that patient's on it for just a period of time, and you should have be very always professional with them. Okay, TRICARE, and I get these two confused all the time. But TRICARE and Chapt. So TRICARE is the insurance for service members. By service members, I mean I'm saying people that are in the armed forces. It is for them, and that means a uniformed serviceman or woman, their family, and their children. Chapt is for veterans. So that is just for people that are no longer in the service, but were servicemen and women, but now are part of a VA hospital or something. But they're not active duty. TRICARE are active duty. And all right. Those are the two for government plans. State children's health insurance plans, that's CHIP. That varies state to state. Not every state has CHIP, but it's an offering to put children on health care should the parents not have health care insurance. It's a short-term plan to cover children in an interim while parents might be looking to get insurance or to be insured. Maybe they were laid off, maybe they were trying to transition from jobs, but that's state children's health insurance plan. Workman's comp workman's comp has to be covered by employers. That's through the federal and the state. So if you're injured, you have the ability to actually obtain insurance, obtain a partial salary to cover you while you're recovering. But that's workman's compensation, and that has to be covered by the employer. Resource-based relative value scale. That's a RVU, and it's a relative value unit, and again, that's adjusted by the geographic adjustment factor. This is how they actually measure physicians by work RVUs. So it's a measurement of how efficient they are, but it's factored by, again, where do you live, where are you located. And I won't get too technical in it, but they actually bring a couple of different companies in, and they blend them. Like where I work, and I'm probably going to guess Harvard probably does the same. We'll use MGMA, and we'll blend with another company called Sullivan Cotter. They'll tell us that, you know, maybe a cardiac surgeon and maybe a vascular surgeon, the expected individual might need to do 10,000 work RVUs a year. And so each procedure they do has a certain amount of work RVUs attached to it. So it's a way of our seeing their efficiencies. And that would be what the relative value unit scale would be for. And it would adjust based on their cost of living and where they are. Payment methods. So, you know, you got to stay within what are the allowed charges. You know, again, like I was telling you earlier, you got to make sure you capture what you do. You know, people are smart shoppers. You can certainly shop around. Everybody's can charge a little bit different, but usually people are pretty close to each other. But they're pretty relative. In healthcare, I mean, I would probably tell you, if you saw something that looked like a super bargain, I'd look at it cautiously. You know, I don't know that show on, you see it on TV, Botched. If you've ever watched, you know, Botched, I don't know if you know the one I'm talking about. These are two plastic surgeons. I think one does noses and one does breasts or something like that, whatever, but it doesn't matter. But what they typically do is try and fix things that people have had done when they've had care done, typically outside of the country, because they've gone somewhere where they could get something a whole lot cheaper than they could get here. So you want to be cautious, because again, if something sounds too good, it usually is too good. Contracted fee schedule, we talked about that, and capitation per month, per member per month. We talked about that too. So calculating the charges, you know, you got to include everything. You got to include deductibles, co-payments, co-insurance, everything gets rolled into it. You know, I won't expect that you figure out how you calculate charges. Balance billing to the patient. So balance billing is just that. You only bill the patient once the balance is determined. If you never want to bill the patient, again, let's make it up. So if we say we want to bill the patient $300 for their visit, you don't just send a bill for $300. That's not balance billing. What we have to do is we have to, let's say I have Medicare. So I'm an 80-20 plan. So if Medicare is an 80-20 plan, and I bill them, let's say I bill them $120, okay? And then Medicare comes back and says, nope, we're not going to pay $120. We're going to pay $100, okay? But what they really mean, because they're an 80-20 plan, they're only going to pay 80% of that bill. So 80% of 100 is $80. That means the balance billing is that we get to send that patient a $20 bill. Does that make sense to everybody? So we charged $120. Medicare came back and said, no, we're not paying $120. We're going to pay you $100. Medicare will then tell the patient, we're going to cover our 80%. So we're going to cover the $80. You owe them $20 to get them to their 100, what we said. That's what they mean by an 80-20 plan. That is why Medicare patients, those that are over 65 or 62 if they want to start early, it's very dangerous to have Medicare and not have a co-insurance, because if you don't have a co-insurance to cover that other $20, it could get real expensive if you got to cover a 20% of a hospital bill. So most people, the elderly, carry some kind of supplemental insurance. With Medicare, you have to, they run a program, and I mentioned it earlier, it's called an ABN, or the Advanced Beneficiary Notice. And that's notice of coverage. So what you do is, if they're in the office and we determine, and we have a patient in front of us that has Medicare, and they're scheduling them to have a procedure, maybe they're having an ultrasound. Where we check to make sure, first, obviously we get the prior authorization, but we also go in and take a look and see, with the advanced beneficiary notice, that is it really covered under your program. So that's the ABN. All right, so the claims process, you want to make sure that you got all the patient information, basic facts. Do I have all the demographics correct? Do I have their phone number? Do I have their address? Do they have the city, state, everything? Do I know their eligibility for the services that were provided? Did we obtain a prior auth? Are we following the coordination of benefits? And they call it the birthday rule. So what they're talking about here with the coordination of benefits is, if you are married and you have a spouse, and both of you carry insurance, and you both carry full insurance and carry each other, and many people do that. The one that comes forward first is the one that's birthday is the first in the year. So it doesn't matter who's older, who's younger. It doesn't matter if one's a male, female, or if you're two males married or two females married. It doesn't matter. The birthday rule comes through and says, whoever is born the first of the year. So if one's birthday is in January and the other one's is in March, it's that January insurance that's going to take the hit first, always. It's called the birthday rule. So delivering services to the patient, that's the practitioner, that's the physician. So those are the people that would deliver the service. You'll always hear a practitioner, or is the provider. Medical coding, that's our coders. They're going to make sure, again, that we are appropriately billing and coding what we say we did, and and what we documented. Because if we didn't document what we did, the billers are always going to come back to us and challenge us and say, you got to take those charges off, because I don't see anything stating that you did it. Doesn't mean that we can't then go in there and put the documentation in, but you can't submit a bill if there's nothing to prove that we said we did it. You got to make sure that you got your referrals and authorizations for all services as well. And then the typical process of patient checkout, making sure that everything is current, up to date, that their ordered and procedures are scheduled for care, if it's ongoing care, if they need to have follow-up visits or whatever. So that's that patient checkout. I do not agree, and I mentioned earlier, I don't agree with taking the copay at checkout. I strongly recommend you get it when the patient is right and running. Electronic claims transmission. I don't know if you're going to do I don't know if you'll do it, and the coders might do it. I think they make you guys do a electronic CMS 1500 form. It's a really long form to fill out a claim completion for Medicare. You don't do it in this course, but it used to be done manually on paper, and it was a ton of work. And now it's done electronically, but I'm not sure if they still have the coders do it, but you might be doing it in other classes. Transmitting claims directly. So how claims work, so we do all of our billing, we get everything ready. Your bills don't go out one by one. So typically how these electronic programs work, they cycle through, and they typically might cycle through, say, like at midnight. And what happens is the Blue Cross Blue Shield bills go out together, the Aetna bills go out together, the Medicare, the Medicaid, they get put together in our systems, and they file out all at once. They don't go out one at a time. That would be very frustrating to the payers to deal with information coming coming in that form and way. A clearinghouse, what a clearinghouse is somebody that does all the billing for you. So if you're a big practice, a big doctor's office, you typically have your own billing department. But maybe you're a small doctor's office and you don't want to do it. You might reach out and have a clearinghouse do it for you, and you just pay them a fee, and they get to take a portion off the fee of what you bill for. And that's determined by the company you work for, if they choose to have do their billing process in-house or do it outside. Generating clean claims. I am not a proponent to have claims go out real fast. Some people really want to get things out quick because they want their money back. I think that actually creates more problems than good, because if you push claims out too fast, you're more at a risk that you actually had an error go out, or that you actually didn't capture what was really truthfully yours. It didn't give the coders the amount of time to actually do the work that you hoped that they would do. So you want them to generate a clean claim, because the cleaner claim, you stand a better chance that there's not going to be no edits. And by edits, I mean the insurance company that you send it to might come back and say, no, we're not paying you. There's an error in this. It might be a diagnosis is missing. It might be you billed on a wrong encounter. You billed for something that on June 10th, when the patient was really seen on June 5th. And they're not going to just say, oh, well, we're going to let it go. We'll pay anyway. That's not how it works. They're going to fire it back to you, and they're going to expect you to fix it. And each time this kind of thing happens, it creates a delay. Okay. And most insurance companies are not going to let you bill after 90 days. So if you keep going back and forth with issues, they're eventually going to say to you, we're done with this. You're not sure about what you're doing here. So you want to make sure you generate your claims, and that they're clean and done the first time. So I am a bigger proponent of taking your time, doing it right, and then we get our money when we first send out our initial claim. And claim security, that's not a big deal. We're not gonna. Okay, so the insurer, the processing of the claims and the payments. So the claims register, they get them. They review the medical necessity. So this is on the other end. This is the insurance company now has gotten it. They review the allowable benefits, and then if they feel everything is in check, you've provided everything, the diagnosis, the right dates there, the encounter is correct, medical necessity was met, you ran the ABN, you got the prior authorization, everything is all good. They're going to send what they call is a remittance advance, an RA. It's your payment. And they're usually electronic. And so the same way we send them, let's say it's a Blue Cross Blue Shield, and I think there's some examples in your textbook. If we sent a batch of patients from Blue Cross Blue Shield, they would have reviewed them all at Blue Cross Blue Shield, and then they would have made the determination if those that met the criteria, and then they would have sent back all of the money that we were entitled to, but it would have been all those patients, and you would have seen them all listed, what they approved, what they didn't approve, and then the very last number would be the total of how much we got paid. So we might get a check, an electronic check for $5,000 for maybe 8 patients. But then after we've gotten that RA, that remittance advance, the money goes into our checking account. It's usually automatic. We can do what we want with the money at that point, and just do our check and balances looking at the RA, the remittance advance. But then we have to do good accounting practice. We have to take that information and then go back to the patient's ledger, because if we got paid, we got to go in there and say, like I think the one we did with Al Navasser had like $114 balance. When we get that $114, we got to go back in there and say, I don't know what his insurance was, but let's say it's Aetna. Aetna gave $114 on payments, and then we log it, and then it zeroes out his balance. But that's what an RA is. It's the money that comes back in from the insurance company. Does that make sense to everybody?
Yes.
Okay. Because there's the point that we've got to send the bill, and that's our sending out the claim. insurance company reviews it, determines what they want to pay. Then when it comes back to us, it's usually electronic. And you know, once the money falls in our checking account, we can do whatever we want with it. But we have to do a good accounting practice. Somebody from the billing office has to go through that remittance advance and make sure that we got what we were entitled to, but that we also go back and do good accounting practice and make sure we document what the patient's actually what the payer paid, and then take it off the patient's ledger. Okay, all right. So that's our chapter on insurance. I'm going to I'll send an email. I apologize. I really wanted to give you the super bill, but I'll send it over the early next week to you with an explanation on how to fill it out. And again, there'll be a story along with it. I think I forgot, it's something Smith. And all I'm really looking for you to do is take the information, the information from her data sheet and transfer it over to a super bill. It's just to have you do the manual exercise of filling one out by hand, because you're actually doing it online with SimChart, but I want you to see it done on hand. Most of us in some form or way have seen a super bill or an encounter form in an office setting when we've gone to see a physician. All right, so the last thing I want to do is I want to give you 2 assignments out of SimChart. So I'm going to be giving you, let me find my book. So we're going to take care of a young kid today. 90. So we're going to do number 22 and number 26. I'm going to be releasing to you. One's on page 94. And the other one is on page 109. So with the first one, you're going to be scheduling an appointment and you're going to be ordering procedures for Aaron Jackson. Okay, so most of these things you've already done. You've already scheduled some orders for other patients, and you've done a couple of appointments for other patients. So, but this they're just going to get a little longer as the patients have their care is a little more complicated. But this guy, he's a young guy. He's just being seen by Dr. Walden. He's got an increased ostomy output and a decreased appetite. Who are the MAs? Do I have any MAs on? Nope. You're all coders?
No, I'm an MA.
So what's an ostomy? No? Okay. So,
off my head.
it's an ostomy bag. So he's got it's a bag.
Oh, bag that's attached to his abdomen. Okay. Yeah.
Right. It's so he's got this little guy. He's a young kid. I apologize for the textbook. I forgot when he's born now. But it's like, I don't know, 2010. But he's really only like 2 years, not even 2 years old. I think he's only like a year old. So he was born with what's called Hirschsprung's disease. And it's a disease where so most of us have what's called peristalsis from your mouth to your anus. Your esophagus constantly moves in a motion, pushing food down in a bolus form all the way from the time we swallow to the time we defecate. When kids are born with this disease, they don't have that peristalsis motion, so they can typically have issues with their bowels, just as this little boy does. So, you know, you're going to be booking some procedures on him. You're going to need to document some of the work that was done in the office in both of these exercises. I forgot now. He was hospitalized. He's on breast milk, which is supplemented with formula. He's sleeping throughout the night. Some activities are delayed for his age. His stool is usually green and foul smelling from the colostomy. And that's not unnormal, because it usually from feces from a colostomy, they're typically they're not formed because they're typically coming from the small intestine. Okay, but because he's having these issues, they order a CBC. Anybody know what a CBC is? No. blood work. So they're looking at his blood count. Okay, they want to see what's his white count, because is he got an infection? Is there something going on? Then they want to do a stool culture, and that's why they want to culture. And what they do is they take a little bit of the stool and they put it in a culture dish that has a growth medium in it. It's almost like a soup to get to, if there is any kind of cooties on there, it's gonna encourage them to grow. So that you're gonna be ordering the CBC, the stool culture, and I think that's it. Yep. And then they ask you to schedule a follow-up appointment. So this one takes a little while. And then his other information, what page should I say? 109. So on 109, it's really part of the same exercise, but you're just going to update his problem list, and you're going to document the vital signs that occurred during the visit. Okay. So this would be something typically the medical assistants or nurses would do in the office. They bring the patient in, get the patient prepped for the physician, do a blood pressure, do a temp check, do all those things, and then they would go and document. And that's what you're going to be doing with that half of the exercise. So those are the two that I'm going to release to you this week, and they're both related to Aaron. Like I said, his date of birth he sounds like he's an older kid, but he's not. And the textbook's just getting a little old. You'll see his little picture. He comes up. He's like about 1 year old. Any questions?
So is this the homework that we're doing like separate from the sim chart?
No, this is the sim chart. So I'm going to release those two assignments to you. That'll be your homework. I do want to send to you the Super Bell encounter form that I was talking about earlier, but I thought I had sent it, but I didn't, and I can't find it now. So I need to send it to you from my office at work. I don't have a copy here. So I'm not worried about that. I can get that to you next week. So those will be the two assignments that you'll have this week. I'll release them after we get off the Zoom. We will not have a quiz next week. So it says it on your syllabus, we got a quiz, just remember. And I'll send an email because there's about 5 of you missing from this. So people aren't studying for something they can't find information on. We haven't covered it. So you can't take the quiz next week. If you haven't taken the test, make sure you take the test tonight after this class. So that's all I have. If you guys have any questions, I hope you're getting some of this. I know this is a really challenging way to learn. So if you have questions, I think most of you have been pretty good about reaching out to me directly, and I'm trying to respond as going into the email as many times as I can. But I think overall you guys are doing really well. I'm pretty impressed. So keep up the good work. If you're missing any of the other assignments, the block style letter or the vendor exercise, get them done. Don't leave them hanging out there. The sim chart exercises, I sent out an email blast over the weekend telling people that were behind have caught up, and that's great. Stay caught up, because they can take a while. They're going to start getting longer and longer. Okay, but that's all I've got. So you'll gain your weekend back. I think it's going to be a little rainy, but it's a weekend no matter. Okay, so that's all I've got. So if you don't have any other further questions, I'll let you go. All right.
All right.
All right. Have a great weekend.
You too.
All right. Bye now.
Ed,
What?
I have a quick question.
Yep. Go ahead.
I'm sorry. I was just wondering if there was anything important that I missed signing on late.
Nope. No.
Okay. I didn't know if there was
No, we just covered chapter 17.
Okay.
I had mentioned earlier that the quiz next week is been moved. So that was
Okay.
the 17th. It's now the 24th. It's also going to push exam 3 out. So and when I determine the date on that, I should know by next week. We did talk about an exercise, a Super Bill encounter form.
Okay.
And I'll be sending that information out, but I will send all the directions with that.
All right.
You've been doing the Super Bill electronically on SimChart.
Okay.
This is just
That's
doing
what I
it
thought.
manually on a piece of paper. Okay.
All right. Okay.
But but everybody's, I think most of you are pretty well caught up. So you're doing okay. You guys got to give yourself a little credit. This is
Yeah, this has been interesting.
yeah. Yeah. It's interesting for you and me. I've never done this.
I can only
they
imagine.
trust me in the past to do it this way, and I think I'm a little too old school, but I'm learning.
I'm with you.
I just don't want to feel like I'm not giving you enough time. So again, if anybody has questions, email me and I will try and respond. I try and look at my emails as many times as I can, but I do forget. So I try and check at least once a day at work.
Okay.
So that's all I've got. That's all we went over today.
All right. I appreciate it.
Yep. So next week we'll go over the information that we're going to cover for the quiz for the following week. All right. And the quiz is going to be pretty simple. It'll be, I think it's about 15 questions. Next week it's about accounts payable, accounts receivable. We'll cover that, and then I'll explain to everybody what I expected them to know for the quiz.
Okay.
Okay.
All right.
Did you take?
You have a good weekend.
Have you taken the exam?
I did.
Perfect. Okay. Yeah, and I actually looked at all the exam grades. Everybody is really doing well, so they will not change. The format will always remain the same, and the final will be the same as well. The final is going to be inclusive of all 3 exams and a little bit of what we cover at the end of the semester.
Okay.
All right.
All right. I appreciate it.
Hey, have a great weekend.
You too.
See you next week.
All right. Bye-bye.
Bye.